Friends, we are so excited you are here for our last live talk of 2024. Our friend and repeat lecturer, guest lecturer is Dr. Joseph Lamb, a dear friend of T4, and I can't think of a better way to wrap up 2024 than with him and his talk on neonatal dermatology. It's going to be a high impact talk that I know will help many people learn about neonatal dermatology, which is a topic that strikes fear in the heart of many. But after this talk, it'll be easy breezy. All right, I'll let Dr. Lamb take it away. Thanks so much.
So thank you very much for having me. I'm glad to be able to present, the last SAGES talk for 2024. The topic will be neonatal dermatology, the good, the bad, and the ugly. I have disclosures, but none of this relates to the talk today, and the slides are completely on my own. And where I'm lecturing from, it's the shared unceded ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh nations here in Vancouver, BC. I have no conflict of interest relevant to the talk, and if I discuss medications, they will be off-label use. Objectives. What we're going to do today is describe benign cutaneous findings in neonates, find some of these findings that are associated with more than just the skin, with systemic diseases, and then list the rashes that are potentially life-threatening, either because of what they convey or just having that rash in itself. With skin, if the skin isn't working well, a lot of things can go wrong, from heat imbalance to losing electrolytes or to infections, and we'll talk about these life-threatening rashes. Outline. We'll start by talking about neonatal rashes that are papular, vesicular, or pustular. Then we'll talk about vascular phenomenon that are there, pigmented conditions in kids, and then the neonatal emergencies as well. And if you take home anything, watch out for the red, scaly baby. Let's start with papular, pustular, and vesicular rashes. Here are some common things that present with bumps in the kids, both the benign stuff and the worrisome stuff, and I'll highlight the ones that are more common. So benign cephalic pustulosis, you might know it better as baby acne. Erythema toxicum neonatorum, super common. So is milia. These are things to recognize, but they're nothing to worry about, and they go away with time. What you want to worry about with anything that's papular, pustular, or vesicular in a newborn is herpes simplex, because that can cause a lot of problems for the baby. Let's go through these one by one. How do you approach a child that has a papular, pustular, or vesicular eruption in a neonate? The most important thing is look at the baby. See the baby's well. Make sure there's no fever and that the baby's growing well. See if there's any risk factors, HSV exposure, and preterm, because if you're premature, and especially extremely premature, it's almost like you're immune deficient and you're at risk for a lot of different diseases. It's useful to know if the rash is localized or generalized. And the big thing to rule out in these babies is make sure it's not HSV, herpes simplex virus, because that can have serious implications. Meet the diseases. Let's start with benign cephalic pustulosis. Super common. You can see this baby over here that has these pustules over the face, head and neck area, even upper chest. Well, what is benign cephalic pustulosis? It's also known as baby acne. And it's not true acne. If you take a look at these bumps, you do not see blackheads and whiteheads that are there, but you just see an inflammatory response. What is the inflammatory response to? Well, it's related to this yeast that everyone has on their skin. This yeast loves oil. So in the neonate, you have maternal androgens that are passed on through the placenta. And when you're born, they start stimulating the oil glands that are there. You don't really see this right at birth, but usually in the first month of life, typically say a week 2 of life, you'll see that the body's reacting to all this malassezia that's there, and you get these papules and pustules that are there, often in the head and neck area and upper chest. Even though it can look fairly alarming, especially for first-time parents, it's self-limited. And the distribution parallels where you have all this oil production, head and neck area and the chest area, and the duration parallels when the oil production happens, because the androgens that are passed on from the mom, they kind of wane and then they fade and they get out of the baby's system. Over the course of weeks to months, these bumps wax and wane and they eventually go away. But if you're alarmed by that, if the parents have paid a lot of money for baby photos and you want to get it gone quickly, you can treat this with topical antifungals to take care of the yeast or topical steroids to take care of that inflammatory reaction that's there. A good one to recognize, because even though there's papules and pustules that are there, the timing, the distribution, a well baby, this is nothing to worry about. And once you identify this, you can reassure the family. Another common condition is called erythema toxicum neonatorum. And even though there's the word toxicum in there, the patients are not sick looking. They don't look toxic at all. But the erythema is a very good descriptor for this. You'll see that there's a lot of redness around these bumps. So what is erythema toxicum? Super common. Up to half of newborns have this. And as of 2024, we still don't know exactly why this happens, except it happens in these newborns. It fades away pretty quickly, and they're otherwise really well. People think maybe it's an immune response to bacterial colonization in the skin, but we really don't know. Usually in the first 2 to 4 days of life, you can see it in the first 24 hours of life as well. The key with this is that the neonates who have this, they're well appearing. And the look of it, you have these papules that are there. On the base, you have this erythema that's there. The papules can become white or yellow and even become full of pus. But recognizing this, you realize it's self-limited and it goes away within 1 to 2 weeks without any treatment. That's erythema toxicum. Milia, another common condition. And here's a newborn with a bunch of milia on the face. You have these white 1 to 2 millimeter papules that are there. It's full of keratin or dead skin cells. So tiny pearly white to yellow cysts. Really common areas are forehead, nose, and cheeks. And really what's happening is you have skin protein, the keratin, that's kind of built up there and just filling up that cyst. For babies who have this, you don't have to do anything for this. Just reassurance, education, and know that it does go away. But it is also very common. And at birth, up to half of regular healthy newborns have this. That's the lineup of the common benign things. What about the worrisome stuff? Herpes simplex is the big one you want to rule out and make sure you're not dealing with. So here's a child who has herpes simplex. The classic look for this is you have vesicles on an erythematous base. But you might not always see them when they have the vesicles. It can become more pustular afterwards. It can be crusted. You want to keep a high index of suspicion for herpes simplex. For this, if it's just skin, eyes, mucous membranes, you treat early with systemic acyclovir. You can treat these kids and they do okay. However, if you don't treat these kids, it can progress to be something much more serious. If you have neurological disease, HSV, it sends a like getting to the brain and it can basically almost rot the brain. These kids survive, but they have a lot of neurological handicap. Not as common, but much more serious is disseminated herpes, and patients can have a high mortality rate if this is happening. So you got to recognize herpes for these babies. What about other things that can give you papules or pustules? Well, you'll notice that congenital candidiasis is on both lists, both the benign list and the worrisome list. How does that work? Well, if you're a term infant, you can get congenital candidiasis that is passed on from the mom, either an ascending infection or sometimes through the birth canal. And it just looks like these papules or pustules that are there generally all around the body. However, you'll find it also accentuated in the areas where it's more moist, like in the palms and the soles. And you see palmar or plantar pustules. You can think of congenital candidiasis. In term infants, it can even be self-limited. And sometimes a hint for that if you have candida in the nails as well. Very different from preterm infants. If you're a preterm infant, you can have papules and pustules, or it can be red all over. That can be life-threatening. It can get into the bloodstream. It can get to the brain. So for term infants, oftentimes it's birth or in the first week of life, and you have these papules and pustules that are there scattered all over the body, particularly over the hands and the feet. But it's self-limited and it resolves in 1 to 2 weeks. And you can use a topical antifungal to treat it or do nothing. The kids often get better by themselves. In preterm infants, a very, very different disease. You can be red and scaly all over with pustules and papules. You can even have the skin broken down with erosive and ulcerative plaques. It's a bad disease if you're preterm. You can get into the bloodstream with candidemia and also meningitis. And the mortality is quite high if they have systemic involvement, and these kids need systemic antifungals. So just watch out for congenital candidiasis. It can present with papules and pustules as well. Other things that are benign is a condition known as transient neonatal pustular melanosis. Not as common as the other things in the benign categories, but it can happen. And the key to this is that you commonly see this in patients with darker skin. And if you catch them right at birth, you sometimes see these sterile pustules that are there. The pustules can even rupture in utero and then leave these hyperpigmented macules. And that's the signature feature of this. The hyperpigmented macules can last from weeks to months. But just know that it's completely benign. You need to make sure if you see pustules in a neonate that there isn't anything else going on. But in a well neonate with darker skin, you can see this pretty characteristic rash. Not that common, but you'll see that rash. In terms of things that are more worrisome, impetigo can happen in the neonates, and this is how it can look like. You get pustules or bullae, and when you're really, really young, you need to watch out for systemic involvement, because that's definitely something that can happen in these neonates, and they are not able to wall off infection that well when they're young. Other things that can be present as papules or pustules are rarer conditions, but I put them on the list so you just have in the back of your mind. There's something with a long fancy name called incontinentia pigmenti. It almost sounds like a Harry Potter spell. It's not. It's a skin condition that is inherited and is an X-linked dominant disorders. So there are a lot of X-linked disorders. Commonly they're X-linked recessive. So if you're a male and you have that, you have one X and a Y, then you have the disease. This is different. This is X-linked dominant, which means if you have the X and you don't have anything else and just a Y, it's often lethal. That being the case, you're not going to see an X-linked dominant disorder commonly in males, but you will see it in affected females. And that's the case for incontinentia pigmenti. There's the IKBKG gene. It controls the Nemo protein, which is an important signal for apoptosis. If you have a genetic change in this gene, basically you get uncontrolled apoptosis. And that's what happens in these babies. In females, you have two X chromosomes and you have random X inactivation called lionization. So in a population of cells, you can have a bunch of cells that have one X that's functionally turned off. And this condition explains why you actually see a line of skin diseases. And it can be one line or multiple lines. Where it's important from papules and pustules and vesicles is that you'll see in the newborns vesicles that go in a line. That's stage 1 of incontinentia pigmenti. That presents in the neonatal period. It's good to recognize this because there's consequences if you have this. Just for completeness, what's stage 2, 3, and 4? Stage 2, it looks more verrucous or warty looking. Stage 3 is hyperpigmented, and stage 4 is hypopigmented. But in the newborn period, you're going to see stage 1. And there, if you have uncontrolled apoptosis, it can be more than just the skin that's involved. In the brain, you can have seizures and developmental delays. In the eyes, you can have retinal pathology and non-retinal pathology, and other features like dental abnormalities, hair abnormalities, nail abnormalities. Many of these consequences are very obvious. If you have seizures, if you have dental stuff, hair stuff, nail stuff. But the eye changes can be subtle, and it can lead to blindness. So recognizing incontinentia pigmenti is important, if anything else, just to send them to ophthalmology early on. If you think of the presenting features of this, where they have vesicles and they have seizures, in a newborn, you do want to think of HSV, because that can also give you vesicles and seizures from herpes simplex virus. The difference is if you ever had to pop a vesicle of herpes, it's very easily popped. In incontinentia pigmenti, the vesicles are deeper. The other clue, it's in this linear pattern. It follows this pattern called the lines of Blaschko. These lines that Alfred Blaschko, German dermatologist in 1901, traced as the pattern of the embryological skin cells. In this condition, because the skin cells in incontinentia pigmenti have this change in the gene, you'll find the disease in the skin follows that pattern as well. So those are the diseases. One last thing to add in your differential diagnosis that can be on a differential diagnosis for many different rashes is Langerhans cell histiocytosis. Not common, you want to keep in your back of your mind, and this can look like many different things, and one morphology of this can be papules or pustules or vesicles. So Langerhans cell histiocytosis, not common, but you have these immature Langerhans cells and a clonal proliferation, like a malignancy. While there's many different presentations, you can see it present as papules or vesicles in the skin, and there's many different organs that can be affected: skin, liver, spleen, bone marrow. We could have a whole talk about Langerhans cell histiocytosis. The point of this is just in unusual cases of papules and pustules or vesicles in a newborn, just think in your back of your mind, if nothing else fits, don't forget Langerhans cell histiocytosis. So those are the diseases that are there, the common papule, pustular, and vesicular dermatoses. Approach to it, make sure the baby's well. Make sure there's no fever, growing well. Look for risk factors. The big thing to watch out for is HSV, herpes simplex virus, because it's treatable. And preterm babies, which are at risk for a lot of different things. See if it's localized or generalized, and see the pattern that's there, and rule out herpes simplex virus if you're not sure. A recent article came out in Pediatrics looking at an algorithm for infants who are afebrile, 0 to 60 days of age, presenting with papules and or vesicles. If you go down the different algorithms, the biggest thing to watch out for here is for HSV. And if you're suspicious for HSV, you're going to treat them until you can prove that it's negative. Let's do a little quiz. Case presentation. Here's a 1-day-old, about 24-hour-old female. Normal pregnancy, normal delivery, and multiple firm yellow papules with surrounding erythema. That's been present for the last 12 hours, but the neonate is well looking. What's the diagnosis? Many people are going to watch this online, so I'll give you about a few seconds to choose the right diagnosis here. If you chose option number 3, you'd be correct. This is erythema toxicum neonatorum, or simply erythema toxicum. Let's do another one. Here's another baby, a 3-week-old male with pustules in the forehead and the cheeks, and a few in the upper chest as well. But this newborn is both afebrile and quite well. The distribution should give you a big hint as to what this is. Here are the options again. I'll give you a few seconds to see if you can find the right choice. And if you chose option number 1, benign cephalic pustulosis, you'd be correct. And here's a 4-day-old female. Brown macules over the arms, the cheeks, and the chest. And this baby's afebrile and well. What do you think is going on here? If you chose option number 6, you'd be correct. This is transient neonatal pustular melanosis. So those are the papular, pustular, and vesicular lesion in newborns. But they can present with other morphologies. And one morphology are things that present in the newborn that are red. We'll talk about some benign things that can happen, some common ones, and some worrisome things that can happen, and then the distinction between these. So some of the common things that can happen in babies: cutis marmorata, super common. Infantile hemangiomas, it happens about 1 in 20 healthy infants. So quite common, but it's in both categories of benign and worrisome. Because as we go through the natural history for infantile hemangiomas where they grow quickly, if it's in an area where it's going to push on a vital structure, it can be worrisome. But if it doesn't, then it may fall into the benign category. We'll talk about nevus simplex, also very common, but a port-wine birthmark, which can be a sign of more worrisome things, and talk about other cutaneous vascular phenomena as well. Let's start with cutis marmorata. This is a baby. You can see the modeling that's there on both feet. This is when the child was undressed, but when the child is warmed, it disappears. This is cutis marmorata. Super, super common. It's a benign physiological phenomenon, and you see it quite commonly in newborns because their physiological response is still kind of immature. What it looks like is a reticular or lace-like eruption, and it's very symmetric. It's transient, and when you warm up these babies, it goes away. Now, this is one of the phenomena that we see because of the immature physiology. There are other things that we can see with the immature physiology, and that's harlequin color change. But there's something that mimics cutis marmorata as well, called cutis marmorata telangiectatica congenita. So many syllables, I'm going to call it CMTC. But these are different things that are related to cutis marmorata. Either it looks like cutis marmorata, but it's different. I'll show you how. Or it's also something that you see in the skin that's red due to the immature physiology. Let's start with harlequin color change. This is an interesting phenomenon that's actually fairly common, but there aren't that many photos in the literature. And the reason why, it's very, very transient. So unless you have a camera ready to take a picture of this, you often will miss this. Fortunately, this is a picture of my daughter when she was born in 2009. And when she had this, my wife was saying, "What's going on here?" And I said, "It's nothing bad, but wait while I grab my camera." Well, what is harlequin color change? It's a physiological phenomena, just like cutis marmorata. Really common, it affects up to 10% of healthy newborns. And it's really neat how you get these transient, clearly demarcated area. It's like a line drawn in the midline of the face and the body. And the dependent area is red, and the area that's not dependent is more pale. It appears between the 3rd and 5th day of life. And the reason why there aren't a lot of photographs in the literature is it lasts from seconds to minutes. But we might see it more commonly these days because parents have cell phones that can take pictures of how it looks. And then even though the rash is gone, they can bring it in. When you see this, it's not a sign of anything bad, and it goes away. What's a bit more worrisome is CMTC. It mimics cutis marmorata, but it's different in a number of different ways. It's often on one area of the body, and then if you think of the reticular or lace-like pattern, the lace is thicker. I'll show you what I mean by this. Here's a kid with cutis marmorata telangiectatica congenita. And with this, or CMTC, you can see it has this kind of lacy, kind of spiderweb-like pattern, but different than the pictures of cutis marmorata because it's a thicker network that's there. Other clues, it's asymmetric, not on both sides of the body. And a big differentiating feature between this and cutis marmorata is that it does not change with warming. The reason why it goes into the possibly worrisome category is it can have associations. So it's over a limb, and commonly it's over a limb. You can get hemihyperplasia, hypertrophy, or larger limb in that area, but more commonly you can get hemiatrophy, or sunken down of that limb. If it's in the arm, it won't cause any functional issues, but it's over the leg and the leg is shorter, that can cause issues for gait and walking. If it's around the eye area, you want to watch out for glaucoma. And if it's over the head and neck and brain area, you want to make sure there isn't any other brain involvement and neurological involvement. So CMTC, it mimics cutis marmorata, but can have some other associations that can be a bit more worrisome. Let's talk about infantile hemangiomas, a very, very common vascular tumor in children, but depending on where it is, it can either be benign or worrisome. Sometimes we joke that hemangiomas, they're like real estate. Location is everything. Same thing for hemangiomas. So it's the most common tumor in children, happens in about 5% of healthy neonates, and has a very, very classic growth pattern. About 80% of them, you don't even see them at birth. It might look like a bruise or a pale area, but usually within the first month, you'll see it growing, and it grows fairly quickly. It stops its growth and it fades away, which sounds great, fading away by itself, but it really depends on where the growth is. If it's pushing out a vital structure like the eye or the airway, even if it doesn't grow that much, you can block off the airway or make it so the brain doesn't know which eye to focus from. That can be a problem. So here are two hemangiomas. They're going to grow, plateau, and fade away, not in a location that will cause much problems at all. But look at these ones. These are ones that are problematic. Around the eye, it can push on the globe and cause an issue. If you have a segmental hemangioma, particularly on the face, you can have issues with how it looks cosmetically, but you can also have underlying structures that are affected with something called face syndrome, PHACE. Every name of the acronym means something, but you can have eye abnormalities. You can have arterial abnormalities. You can have brain abnormalities, and sometimes heart abnormalities as well. Certain locations can cause problems because as you grow really quickly, you can outstrip your blood supply. And sometimes if it's in an area where the skin is very moist, like in the armpit area, the bum area, the neck area, you can have the skin ulcerate. And that's what's happening in this patient. So although most hemangiomas are fine, there's certain locations that are problematic. Around the eye, airway, facial segmental hemangiomas, or areas where there's friction, you can ulcerate as well. Let's talk about nevus simplex as one of the benign phenomena. Really common as well, and good one to recognize. Here are two patients with nevus simplex. Here you can see some redness above the eyelid, and if you look closely, in between the eyebrows on the forehead, kind of like a V-shaped distribution, this area is called the glabellar forehead. You can see there's a pink patch here. The borders are kind of fuzzy, and that's what you often see for nevus simplex on the forehead area. This is completely benign. And in fact, the ones in the facial area, fortunately, they fade away with time. About 95% of them are gone or almost gone by 2 years of age. Interestingly, when the child is warm or upset or crying, it can make it look a bit more flushed in the area. You can also get a completely harmless nevus simplex on the back of the head, near the nape of the neck, and sometimes at the vertex. And that tends to not go away with time, but the solution for that is just hair that grows and covers it. So nevus simplex, also known as a stork bite or an angel's kiss or salmon patch, really creative names. I guess here in the forehead, it's like an angel's kissed you, or on the back of your neck, it's like I have this image from a Disney cartoon Dumbo, where the stork picks you up in the nape of the neck and then brings you to your parents. These are completely benign, and these are the common locations for nevus simplex. Present about 80% of newborns, so something good to know. The ones in the glabellar area, the eyelids, the philtrum, it fades typically by 2 years of age. But the ones in the base of the neck, it persists. But regardless, they are benign and they're not worrisome at all. So those are the nice benign ones. And the worrisome one, port wine birthmarks. Not as common as a nevus simplex, but it's something to keep in mind because it can have other associations. And here's a kid with a port wine birthmark. It's flat as opposed to the hemangioma. It's present at birth as opposed to the hemangioma, but there are risks with this. So what's a port wine birthmark? It's a capillary malformation, so malformation of the small blood vessels in the skin. Unlike the nevus simplex, 80% of newborns or so, unlike the hemangiomas, 5% of newborns, this isn't as common, 0.3 to 0.5% of neonates, and it doesn't fade with time. And it's important to know for these kids that sometimes the blood vessels can even thicken as patients get older, like in the teenage years or when they're adults. Forehead port wine stains, they're associated with glaucoma and neurological issues. You got to watch out for that. And that's the main thing for the port wine birthmarks. Interestingly, in old textbooks, it mentions the V1 nerve, V2 or V3 distribution, but recently it's been found that it's the ones that affect the forehead that have issues, and if the forehead is not affected, you don't have issues. So it's not so much V1, V2, V3, but forehead involvement. So those are the red diseases that we have to watch out for, and let's do a quiz. So case presentation. Here's a 3-month-old female, a red patch over the mid-forehead, present since birth, and gets more red when she's crying. I'll give you a second to look through the options and then guess what you think the diagnosis is. So for this, right here in the middle forehead, if you look at the edges of it, it's not sharp and distinct like one straight line, but it kind of, if you have to trace the edge, it's kind of feathery. All right, so if you guessed answer number 2, you'd be correct. This is a nevus simplex, and here's a picture of other patients with a nevus simplex. Super, super common. Even if you're not going to dermatology, if you're going to family practice and pediatrics, you're going to see lots of this. Even if you're not seeing children, once people know that you're a doctor, they're going to ask you for their kid, hey, what's this rash? If you see this, you can say, oh, it's not a problem at all. Sometimes people Google port wine stain or port wine birthmark, and they worry about all the associations with that. With the nevus simplex, there's no association with the complications. Here's the nevus simplex in the nape of the neck, and here you can also see it on the vertex. And with these ones, the redness does not go away. So the ones that are visible in the face, fortunately, they do go away as patients get older. But the ones in the back, the nape of the neck, and the vertex, they tend to persist. And this is an older kid where you can see there's still that stain that's there, but hair covers it up. Here's a 6-week-old male with a red plaque over the left chest. It wasn't there at birth. It was noted at 1 week of life, and it's increasing in size. That's how it looks on the chest, and the question is, what's the diagnosis? Same options. I'll give you a few seconds to see what you choose. And if you chose option number 6, that'd be correct. This is an infantile hemangioma. Another case, a 1-day-old female, normal pregnancy, normal delivery. Actually, no. Sorry. This is not a 1-day-old. The case is a bit off. This is a patient who's a few months old. This is there at birth, and this persists. It doesn't disappear within minutes, and it stays there on the left side of the face. What's the diagnosis here? If you guessed port wine birthmark, that would be correct. And here, this is just to demonstrate that location does matter. If you have a port wine birthmark that affects the forehead area, those are the ones that are associated with brain and eye involvement in what we call Sturge-Weber syndrome, and not the V1, V2, V3. It's interesting when people trace the pattern of the vascular stains, it actually follows the embryological vascular pattern, and it doesn't even trace or follow the nerve pattern. And similarly, if you have problems, it's the one that involve the forehead area. And these are the high-risk zones for Sturge-Weber. The forehead is involved, especially both sides. But these are the patterns, even if it's localized, if the forehead is involved, that's what we worry about. Either just the forehead or forehead and the face. And that patient is at high risk for Sturge-Weber syndrome. Management, if you see that happening in these high-risk phenotypes, get ophthalmology involved. This is another condition where you can have silent eye disease, and you can have high pressure of the eye, glaucoma. There's no evidence for MRI screening for pre-symptomatic patients, and some people have toyed around with the idea of EEG screening for these patients. But you want to have early referral to neurology to monitor. And you want to treat this. There's good evidence for pulsed dye laser to treat the facial port wine birthmark. So those are the red lesions. We'll move from papulopustular and move from red lesions to black lesions. So black and blue, talk about congenital nevi, something called dermal melanocytosis, and then blueberry muffin baby, which encompasses a lot of things that are in the blue differential diagnosis, including vascular lesions. So congenital nevi, why are they in both categories? Because the ones that you're born with can be quite large. And if they are large, and especially if they have lots of satellites, they can be associated with not just skin involvement, but brain involvement as well. And the more pigmented cells you have, there is a higher risk for melanoma occurring. But it's important to know about the neurological issues. So here's a patient with a congenital melanocytic nevus. You can see it's quite brown with black spots there. It's a collection of melanocytes or pigmented cells in the skin. It can be anywhere on the body, and typically they're present at birth. It's important to note that sometimes they can present within the first 2 years of life and look exactly like one of these large ones at birth, but you don't actually see anything at birth. They're called late congenital nevi or nevus tardive. They typically grow in proportion with the child. Oftentimes when you think of pigmented lesions and complications, melanoma can be the first thing that comes to mind, but just know that the melanoma risk is there, but it's quite low, and less than 1% for small to medium congenital nevi. And believe it or not, medium by definition is less than 20 centimeters projected adult size. So even some of these ones that are quite big on the skin, the risk of melanoma is low. If you have these giant congenital nevi, the risk is only 2 to 5%, which means patients like this who have a really large congenital nevus, 95 to 98% of them don't have any problems through the rest of their life. If they do have problems, half of the patients are diagnosed early, and it can look funny sometimes in melanoma. It can look more red. Risk factors include multiple satellites, size, which may be a marker for truncal distribution, because if it's big enough, it's probably going to overlap the trunk as well. More worrisome than melanoma, however, is this thing called neuromelanosis or neurocutaneous melanosis. You can have these melanocytes in other places where they don't belong, in the CNS or in the or sometimes even blocking the CSF or the cerebral spinal fluid. And some of the symptoms can be seizures, hydrocephalus, increased intracranial pressure. There's a recent guideline that came out this year, which talked about MRI screen, or actually not this year, 2021, so 3 years ago, talking about when to consider screening for patients. So if you have a giant congenital nevus, greater than 40 centimeters projected size, multiple medium, or lots of satellite lesions, and you want to look elsewhere, like in the brain. Here's a picture of a patient who has lots of satellites. You can imagine with all these melanocytes here, it can be other areas like the brain as well. That's congenital nevi. Let's talk about dermal melanocytosis. It's also known as Mongolian spots, dermal melanocytosis. And what we see here are melanocytes that are deeper down in the skin, which gives it the blue color that's there. So other names, slate gray nevus, Mongolian spots. What's happening here? These are melanocytes that are migrating to where they should go, but they're kind of slow to get to where they want to be. And if you look at ethnicity, you'll find that the prevalence varies. In Asian populations, 40%, 30% in Black populations, but not that common in white populations. The good thing about this is that in the typical location, like in the back, many will start fading away in the first decade of life and not worrisome at all. What can be worrisome is this creative term called blueberry muffin baby. What we're talking about is that this is a term coined in the 1960s, where there's a rubella outbreak in America, and if you have a mother with rubella, it can affect your bone marrow production, and then you get, instead of having your bone marrow produce red blood cells, your body says, I need the red blood cells, and you can get your skin to produce red blood cells, and you get these interesting blebs that represent what they call dermal hematopoiesis, or the dermis actually creating blood because you're low. And since then, they found that other infections that suppress your bone marrow can do that as well. It's not just infections that can make you low in your red blood cells. If you have hemolytic disease in the newborn, you can actually see blueberry muffin baby. And here's pictures of people, of newborns with congenital CMV, and these blue or violet spots are due to the body trying to make red blood cells there. We realize that after a while, it's not just things that affect your red blood cells, but you can actually have things that infiltrate into the skin that gives us blue look. And I'll show you that neuroblastoma. Here you actually have metastases in the skin that look kind of blue. You can have acute myeloid leukemia, like in this child, where the leukemia is there in the skin, looking bluish. Langerhans cell histiocytosis, as we said, it can look like many different things. A whole bunch of vascular lesions. And here's a patient with a hemangioma that looks kind of a darker red color. And this is a patient with something called a glomus tumor And you can have venous malformations as well that look blue in the skin. And then sometimes neonatal lupus can look like this blueberry muffin as well. So that's black and blue. We're going to end this talk by talking about emergencies that happen. 3 emergencies to know: epidermolysis bullosa, if the skin is fragile and sloughing off; something called collodion baby, which is where the babies come out looking like they're wrapped up in saran wrap; and erythroderma, which is a very specific term for 90% or more of the body surface area red and scaly. If you see that in a baby, this is worrisome. This is a patient with epidermolysis bullosa. The skin is fragile. They sometimes call these butterfly children because their skin is as sensitive as butterflies' wings. A group of inherited blistering disorders, and you have this mechanical fragility. So blisters of the skin and also the mucous membranes. Here are a whole bunch of different proteins that can be knocked out. This is the skin. This is the epidermis. This epidermis is up here. Dermis is down here. If you're missing some of these pieces, then the skin can fall apart very easily. And just know that there's a whole bunch of different genes that can cause problems, either in this up in the epidermis or the dermal epidermal junction, or in the dermis, collagen 7, that can cause a split in the skin. Here's a picture of different patients, and you can see that the skin is sloughing off. If you see this, call pediatric dermatology or call dermatology. These kids need to be managed, and this is an emergency. How do you manage these kids? Well, make sure they have enough fluids and electrolytes. If you're putting the IV in, if they need that, make sure that you don't tape the IV to the skin. There's different ways where you can get it fixed by wrapping around or having things that are more tacky and not sticky, because if you're taking the tape off, you can rip off more skin. Radiant warmer and isolate. If their skin is sloughing off, they can lose a lot of heat. And make sure they have minimal handling, no tapes, no adhesives, but there's creative ways to keep things fixed in place. The diapers cut off the elastic, because just the rubbing from the elastic can make the skin shear off. And lift the baby instead of from the arms, from the head and the buttock area, just so there isn't that shear force on the skin. And then there's different ways you can change. You get the dressing on and you can change your dressing, but you want to make sure that you don't traumatize the skin. Warm water, mild cleanser. You want to drain the blisters, because the blisters are tense. It can actually cause the edges to start splitting as well. So you can drain the blisters, and you want to have a petroleum-based ointment so there's no stick on the skin. Get the dressing on top. Instead of taping it onto the skin, you can roll a dressing over that. And that's a baby with some of the dressings on the arms and the legs. EB, or epidermolysis bullosa, emergency. Collodion baby, another emergency. If it looks like there's a shiny taut membrane around the skin, that's what it looks like with the collodion baby. In epidermolysis bullosa, if the skin is sloughed off, you don't have the skin working properly, run into issues. Same thing with collodion baby. Even though the skin is there, it's not functioning properly. And these kids are at risk for a bunch of issues just from how the skin is not functioning. It presents at birth with shiny taut skin, and many of these patients have an underlying disease that is ichthyosis. Ichthyosis is undergoing a name change. It's going to be called epidermal differentiation disorder. But yeah, ichthyosis or EDD, same thing. You can have ichthyoses that are non-syndromic, and they just have dry skin. But just know that some of these ichthyoses can be syndromic as well. And there's other rarer conditions that can uncommonly be associated with collodion baby. With the collodion phenotype, when you see a baby like this, it's sometimes hard to know what's the underlying disease, but the collodion will shed over the next 3 to 4 weeks, and you'll know the diagnosis hopefully once the collodion sheds. But when the skin isn't working well, like in the collodion, the patients need supportive care. So they're at risk for high water loss, sometimes more than regular skin. So they have to take care of that with an incubator. Heat loss as well, because the skin can't keep the heat in. Again, a humidified incubator will help with that. Same thing with temperature instability. If you get dehydrated and you lose free water, you have more concentration of your salts. You can get hypernatremic dehydration, increased caloric expenditure, and also since your skin isn't working properly, increased risk of infection. So to deal with that, you want to have these kids admitted to the ICU, the NICU, high humidity incubator. They'll help take care of the water loss, the heat loss, the temperature instability, the dehydration, and monitor closely for infection, and monitor closely making sure that they're gaining weight. Last emergency to go through is erythroderma. And what is erythroderma? Erythroderma is red and scaly skin, 90% or more of the body surface area. I find Teletubbies kind of scary, but if you see a kid that's red and scaly, that's also very scary. Erythroderma, redness, erythema, and scaling involving 90% or more of the body surface area. So with this, I think it's easy. I like to think about this with the 6 I's. Ichthyoses. There's a form of ichthyosis that used to be called CIE, or congenital ichthyosiform erythroderma. Erythroderma being red. Immune deficiencies can present. Inflammatory conditions, I'll show you examples. Infection, inborn errors of metabolism, zinc deficiency, amino acid deficiencies, and iatrogenic. I'll go through these one by one. So ichthyosis, you can have the autosomal recessive congenital ichthyoses, and this is a patient with one that used to be called CIE, congenital ichthyosiform erythroderma, and they're quite red. Immune deficiency, there's something called Omen syndrome, head to toe. You can have redness and scaling, and this is one that's both an ichthyosis and an immune deficiency called Netherton syndrome. Inflammatory conditions, you can have bad eczema, head to toe, and this is a patient with psoriasis. Infection, so here's a patient on the left with something called staph scalded skin syndrome, and you get blistering and redness of the skin. And then, as we mentioned earlier, congenital candidiasis can make you red and scaly, or make you red all over. Inborn errors of metabolism, if you have zinc deficiency, classic zinc deficiency around the mouth and in the perianal area, and also the hands and the feet, but it can also be all over. And this can happen with true genetic zinc deficiency called acrodermatitis enteropathica, or you can have it in if you are missing certain amino acids or proteins, and that's acrodermatitis enteropathica-like. And iatrogenic, just know that babies, their skin is fragile, especially preterm babies. You can have chemical burns if you're not careful. There's a case of someone who's cleaning the umbilical stump with chlorhexidine, and other cases where in the preterm, if they forgot to wipe off or take off where the chlorhexidine may have pooled underneath, you can get a chemical burn that makes it red. Or this is a case of not even a medication, but something people are using at home from a traditional alternative therapy where they use wood ash, and that causes a severe chemical burn on the neonate. So those are the list of a bunch of causes that can give you erythroderma, and just know that it's an emergency because the skin barrier isn't working. That's a list, but underlying causes in real life, it's a good one to know, because if you look at some of these rare conditions that are on lists, it shows up in neonatal erythroderma. And if you look at immune deficiency, almost a third of the patients have immune deficiency. Ichthyosis, Netherton syndrome, things like eczema, psoriasis, not as common, and sometimes not yet diagnosed. So here's a case series out of France looking at cases of erythroderma, and a good chunk of these kids had ichthyoses, and a huge chunk of them, even more than ichthyoses, had immune deficiency. So it's good to know if you see that, it's an emergency. So beware the red scaly baby. Management, the skin isn't working well, so you're at risk, just like with the collodion baby, just like with epidermolysis bullosa. You can lose heat, you can lose free water, and you can get dehydration, that's hypernatremic hyperpyrexia, just because of all the inflammation that's happening. Also, you can have low temperatures as well. So you want to maintain oral intake, and if they need IV fluids, watch out for the electrolytes. Hydrate the skin, but watch out, you can absorb more through the skin, and then look for the underlying cause, because many of these causes can be worrisome, need to be treated. Let's do a couple quizzes before we wrap up. Here's a 6-week-old infant. This baby was seen at the Children's Hospital in Vancouver. Widespread eczema since birth. And since she was darker skinned, it was hard to appreciate the redness, but it was quite red all over, but not very scaly in this case, more bumpy. Parents are consanguineous. They were first cousins, and she was admitted for Klebsiella sepsis with a normal T cell count and elevated eosinophils. what's going on? Is it just bad eczema? They need to use more steroids, need to cut out cow's milk, problem with their T cells, or a problem with their mast cells? If you guessed option number 4, that's the right answer. And here, if you look into blood work, she had a normal T cell count, but if you actually look at the T cells, she had an abnormal T cell clone that was not even functional. And a clue to something called Omen syndrome is elevated eosinophils. And that's what she had. Omen syndrome is a rare primary immune deficiency, and you have both your B cells and your T cells that are affected, and you have this abnormal clone of T cells that are not very functional. But the key from a skin point of view is that erythroderma. That's one of the things you worry about, and you want to make sure that you think about the options or involve your subspecialists to take a look at this kid. To summarize, we talked about benign cutaneous phenomena in kids, and then eruptions that are associated with more systemic diseases and things that are potentially life-threatening. We divide into categories of papular, pustular, vesicular, both the benign ones and the worrisome ones. We talked about red lesions, things that are common, things that are less common, and things to watch out for, black and blue lesions, and a whole list of blueberry muffins, and then the emergencies, the epidermolysis bullosa, collodion baby, and erythroderma. And that brings us to the end. All you need to know about neonatal dermatology. Actually, there's even so much more to neonatal dermatology, but hopefully that will just whet your interest in all the rashes that can happen in our babies.
Yay! Amazing. That was so good. I feel like I need some holiday cheer with that as well. Because it was so good. And yeah, thank you for this amazing talk. You covered so much good stuff in such a short time. So pertinent for everybody out there that's a dermatology resident or a dermatology learner. And again, those common things that are not bad. Wow, you're going to see those. Your family members are going to ask you about it. You're going to see those things, even again, if you're not a dermatologist. So, kudos to you. What a great way to wrap up our last live talk of the year. Yeah, and I will be doing a wrapping up 2024 and tying it with a bow, a little summary, pre-recorded summary of all of the wonderful talks we've had and all of the amazing T4 speakers. We'll hopefully be submitting some questions. Dr. Lamb always includes them in his talks, so he doesn't have to work hard to do that at all. But we're going to put together basically a summary of questions from the talks over the last year, just to make it really high impact, tying it with a bow, if you will. So, and tying it with a bow, talking about that, Dr. Lamb's bow tie, which he tied himself. So cool and so holiday festive. So bringing out our holiday best for our T4 friends. So anywho, thank you again for this amazing talk. And I will tell you, I did get all the quiz questions right. So I'm very proud of myself because I wasn't sure if I would, because I always learn something from you. But yeah, as far as HSV, it is one you do not want to miss. And it is a great masquerader. And I've only been asked, to be a kind of expert witness a few times in my life. And it's for laser injury of kids that are, inappropriately treated at med spas, basically, when they're skin of color, for the most part. But the only other ones I've been asked for are neonatal cases, that were HSV related that were missed, and the kids had long-term sequelae that could have probably been prevented. Sometimes you can when you intervene, but sometimes you can't, but you don't know if the diagnosis is missed. So anyway, definitely an important one. And you must have been kissed by the dermatology angels with having your daughter have a harlequin color change, like, holy cow, then you cut it on photographic evidence of. So congratulations on that. That's amazing. How old's that daughter now?
She's turning 16 in February.
Oh, wonderful. Yeah, and it passes quickly. But unfortunately, the teen years don't pass nearly as quickly as the harlequin color change.
So true.
So true. And then the melanocytic lesions, yeah, and you had a on dermal melanocytosis that basically, yeah, it does resolve. And the one association is the mucopolysaccharidoses, like hurlers and hunters. And I did see one of these in my residency. And they hadn't picked it up in the ER, but they just called us over because the baby had just extensive and had some other things going on, but they hadn't put the whole picture together and nobody really could. So they called us over and I brought up the mucopolysaccharidoses and the kiddo ended up, I can't remember which one they had, but they did have one and the baby was really floppy. Like that's the thing that
Right.
I noticed, like they had very extensive diffuse dermal melanocytosis, but that baby was so floppy and that can
Yeah.
be a sign of that too. So anyway,
Extensive, persistent Hunter Hurley's GM1 gangliosidosis, and they often have big livers and spleens by that point already.
yeah, exactly. So anyway, that was a good pickup that we made as dermatologists to help with
Yeah.
the overall diagnosis.
Well, the flip
And
side is that sometimes
then,
patients are misdiagnosed as child abuse, especially if you don't
yes,
have a population that has a lot of patients with skin of color. And it's good to
yes,
recognize, oh, that's not bruising.
yes, exactly. A good point, a very good point. So yeah, all of those things. And then there was one more thing I was going to bring up, but I'll just have to think of it and bring it up in my talk in a couple weeks as we
Stay
wrap
tuned
up.
in the new year for that one extra
Yeah,
point.
that one little extra point, that'll be where we launch off. But yeah, we are looking forward to having you back in 2025 for sure. And I know you said you had a Langerhans cell talk, which would be really great to share because that is a big diagnosis in itself. Um, or whatever else you want to talk about. I give you.
So many things mimic Langerhans cell.
Yeah. I guess what it was epidermolysis bullosa. It was a needle in my brain, so I'm glad I just pulled it out. But with EB, yeah,
Yes.
our PD derm colleagues have done such
Mhm.
great work with that disease. And, we know so much more because of the work of our colleagues. And the one thing and you might be able to better pronounce the dressing name. I know we're not here to push any certain dressing, but it was a Canadian company and it starts with M and I always butcher the name Monlika, do you
Monliki, do they make like Mepitel and Mepilex?
Mepitel, Mepilex, all of those. Those are such great products for that patient population. And you can usually get them in the hospital because, again, there's so many other things that you can use if you don't have access to those, but they are very atraumatic and patients tend to love those products. And I know they are Canadian based, just like you. So anyway, and there are new treatments out for that, two
There are.
FDA approved treatments, which is
Yeah.
just really miraculous that, I wasn't sure I would ever see that in my career. Because, like it gets called EB is aside from the butterfly disease is the worst disease that you've never heard of.
Yeah.
And it really is true, but there's hope on the horizon for so many of our patients. And
There's
yeah,
bark terpenes that are there, and also like HSV vector gene therapy. Expensive. I don't think they've come to Canada yet, but at least there's some headway, more than just, bone marrow transplant.
yes, exactly. And we will hopefully, again, maybe be looking at the bird sheep terpenes for potentially AEC syndrome and the erosions with that as an
Mhm.
investigator initiated trial. That's a disease that I've studied. Elaine Siegfried, my mentor, has studied, and she's still involved with the National Foundation for Ectodermal Dysplasias. So we might be getting an investigator initiated trial off with that and the team. So I pray for that because that's another disease and a disease state and patient population that I've prayed for a treatment because those erosions of AEC are as bad as epidermolysis bullosa. So anyway, lots of hope on the horizon as we wrap up 2024 and launch into 2025. But thank you again for our last live talk of the year. And I look forward to wrapping up and tying it with a bow with our friends with a pre-recorded lecture in a couple of weeks. So we'll see you then. Thanks so much.
Thank you. Have a great day.
Bye-bye. You too.